facilitator for the NHS Time for Care faculty, which is training and supporting primary care and quality improvement. He's also clinical advisor and entrepreneur for the Royal College of GPs. He recently joined the Scientific Advisory Board for the Public Health Collaboration. I had the pleasure of meeting Campbell 5 months into my own low carb journey 3 years ago, and until that point I felt completely and utterly alone. I didn't know anyone else that knew about low carb or was advocating low carb. And then I met Campbell, and it's just given me goosebumps just saying that, because I suddenly didn't feel alone anymore. So his knowledge and his passion is just so inspirational, and I'm really proud to have him in Somerset, which is where I come from. So over to my friend and my mentor, Campbell.
Catherine asked me just to say, how would you introduce yourself? Just highlight it. I wrote all of that. It was really great to be here. I became a fully qualified GP in 2007, and then went on to study sports and exercise medicine. With the main interest I have is what is it to be human, and how do we optimise our health, well-being, performance, whatever that is. And what really gets me up every morning is the cliche quote is there are 7.7 billion people on Earth with a lot of needs. There's a lot of sick people that don't need to be sick. And as a journalist I was speaking to recently framed it, we have an epidemic of diseases that shouldn't exist, but we've kind of normalised that in primary care. And this is what's now is totally breaking primary care, and why we have no resources for our mental health services. So what drives me is actually these are fixable problems, but we need to know how to go about it. We've been on a journey, I think, over the last probably 5, 6, 7 years, 10 years, and then when you look back over history, a couple of 100 years of shifting paradigm to away from we get sick as we get older, we get all these diseases. It's just what happens, and we've learned in our medical training or other health training that we treat disease. That's what we do. Humans get sick and we treat it. When your eyes start to open to think, hang on a minute, we are doing something wrong, or this doesn't make sense, or I've seen an inkling of something that what I've been doing for the last number of years isn't appropriate, it hits you pretty hard. It certainly hit me pretty hard, because you've got to go through that experience equivalent to when I was 12 years old and broke my neighbour's lawnmower running over a big rock. Put that lawnmower back in the garage and you get that horrible gut-sinking feeling of what's going on, what have I done? But I think what's nice now where we are is we're through that, and we're doing things like this now, and it's no longer about a battle, it's about actually how do we skill up. So that really leads on to what I'm going to be talking about is actually now vast majority of healthcare professionals, and certainly vast majority of people within primary care, we're pragmatists, we see patients, we see what happens. Any resistance to change is not going to be because we don't want to do the right thing, or we're resistant, we're going to stick with what we always did because that's what we do. Resistance is going to be because we're not sure what to do, we're not quite sure how to take these steps. So it's not a proactive resistance, it's just a bit we need to do some practical learning. So with that, I'm going to be talking about adapting type 2 diabetes medication for a low carbohydrate diet, or, and again this term low carbohydrate has cropped up a lot. I cannot wait for the day when we just say normal food. Go back over human evolution. Low is only low compared to high, and we're just moving to low from a period of high for over a few decades. But people have been on a high carbohydrate diet, they've got a load of drugs, and they're about to reduce that carbohydrate intake. What do you do with their drugs? There are not that many clinical duties in type 2 diabetes remission, but adapting medication is one of them. So I just realised I go back into the camera. Okay, so I thought I'd start with a case study. Very, very close. It's been adapted slightly just for confidentiality, but 64-year-old male, type 2 diabetes for 15 years, hypertension, non-alcoholic fatty liver disease, CKD3, obesity, IBS, the breast. So, again, not an unusual patient in primary care, unfortunately, these days. That's pretty standard. Most recent blood results, HbA1c of 74, ALT 72. So this epidemic we are seeing of non-alcoholic fatty liver disease. Again, that's not an unusual ALT. We kind of look into it a bit, we get some scans, we do all those blood tests for all the things that you learn you're supposed to do when somebody hasn't got fatty liver due to alcohol. They're always negative now. They've all got non-alcoholic fatty liver. Triglycerides were higher at 3.2. I hope after today, all those high triglycerides coming in, you now know it's linked to poor metabolic health. It's not something you just ignore. Low HDL cholesterol again there, high blood pressure, BMI 40.2, weight 130 kilos. So again, not an unusual profile now. Medication, I've added a few extra onto the end of this just for the rest of the session, but what I want you to do is, if you go through these medications, is on one hand mark the medications actually that won't need to be adapted or unlikely to lead to an if you do the lifestyle change, is it likely this medication will need to be continued? On the other hand, if you do the lifestyle change, is it likely the medication may be stopped? So you don't have to show anyone else, but glycoside, okay, put a finger up on one of your hands. Metformin, liraglutide, loperamide, ramipril, atorvastatin, citalopram. So that was actually a real list of the patients on all of those, and I've added these on at the end for the sake of the presentation. Alogliptin, empagliflozin, levodopa, and novorapid. Okay. Now, if you're brave enough to, lift up your hands with how many you think might be able to be altered or reduced or something. Yeah, pretty much all. Good. Excellent. So we'll see as we go through this what good healthcare is about. Lifestyle-wise, they were following a low-fat diet, and they really were following a low-fat diet. They set themselves up to properly do it, and they were going to the gym and doing a fair bit of cardio exercise. So learning objectives, I'm really keen from this session you leave with something actually, okay, tomorrow, or Monday now when I'm at work, this is what I can do differently. So there's know the three key considerations for deciding what to do with diabetes medication when somebody with type 2 diabetes reduces their carbohydrate intake. Know how to adjust the drugs that risk hypoglycemia, and I'm going to drive the learning point in a few times, so I've told you them here. So sulfonylureas, meglitinides and insulin, you need to address those once you reduce carbohydrate intake. Be alert of the drug that can cause ketoacidosis, which is the SGLT2 inhibitors, the flozins. Out of interest, quickly, who has seen ketoacidosis with these drugs? Put your hand up. A few people. So a known risk with these drugs is ketoacidosis. I'll label that again in a minute. And then finally, you'll be able to consider the drugs that have no short-term risk, so you can continue them, but you need to review the risk-benefit profile once somebody's health has improved and you've altered their diet. This is all based around a paper that I wrote together with David Unwin, David Cavan, who was on earlier, a doctor in the States, Mark Cucuzella, and the diabetes lead for the Royal Pharmaceutical Society. This is open access, British Journal of General Practice. Just type in adapting type 2 diabetes medication, low carbohydrate, BJGP, and you'll get it. It was paid to be open access by PHC, so thank you very much, PHC. The journals have to make their money somehow, but we thought it was really important that this is open access, so patients can also access this. So 3 key considerations, what are they? 1, is there a risk of the drug causing hypoglycemia or other adverse event? So you're about to change the diet, ask this question with the drug. As they reduce their carbohydrate intake, could this drug cause a serious adverse event or hypoglycemia? 2, the question to ask is, what is the degree of carbohydrate restriction? Obviously, if you're going from a very high carbohydrate diet to just a little bit lower carbohydrate diet, that may not make much of a difference. If you're going from very high carbohydrate to a ketogenic diet, that's obviously quite a bigger difference, and you need to think more through that more. And then, once the carbohydrate is reduced, does the drug continue to provide benefit? And if it does continue to provide benefit, are the risks of that drug still less than the benefits? Okay, that's standard risk-benefit. Okay, so those are the 3 questions to answer. So first of all, the sulfonylureas, and I've never used meglitinides, but as I understand it, they do the same thing as sulfonylureas, which tell the pancreas to kick out more insulin, regardless of whether or not it needs to. So they increase pancreatic insulin secretion. Anyone like to volunteer any thoughts on what you'll do if you reduce carbohydrate intake? Yeah, you're going to risk hypos, aren't you? So again, generally speaking, I will stop it. However, if somebody's maybe got an HbA1c of 80 or 90, and you're thinking actually stopping it, their blood glucose is going to rocket in the short term, because there's a bit of time it takes for the body to fix itself. You could just go for a 50% reduction initially. Obviously, they're going to have testing strips. Probably none of them have been testing for the last few months because they don't, so you have to reiterate, make sure you're testing, and then the dose can be dropped again. Kind of drop it at 50% increments. You can stop it as soon as you're no longer worried about a significant hyperglycemia. Okay, so straightforward, fairly simple, isn't it? Next, insulins. So they block the liver from making glucose, and they also encourage glucose uptake, obviously. Any thoughts on what you might do with insulins when you reduce carbohydrate intake? You've got to reduce it, haven't you? Yeah. What do you do if you increase your carbohydrate intake? Increase. How did we get so hooked on giving people loads of insulin? How do we make nutrition guidelines to encourage people to take insulin? It's nutrition guidelines for diabetes have been based on how do you get more drugs into people. And you still get this from colleagues who are well-intentioned, but the patient needs to eat carbohydrate because they have to take their insulin or sulfonylurea, which is kind of backwards, isn't it? It's a funny way of looking at it. So general rule of thumb, reduce the dose by 30 to 50%. And I don't want to give anyone any hard and fast guideline for this, but as a general theme, it's 30 to 50%. It's obviously dependent on the patient, their situation, but that's a fairly safe bet. If they're on a combination, so if they're on a long-acting and they are using a short-acting as well, if they're going to go for a proper low-carbohydrate diet, where they're actually not going to have much carbohydrate with each meal, you obviously can just stop the short-acting. And the general approach is to take the short-acting number of units, the long-acting number of units, add them together, half it, and that's the new long-acting dose. Okay. I'm going to give you another resource at the end. If the HbA1c is greater than 80, then you might think let's just drop it by 30% initially. Okay, is that clear? I've put in red there a caution, and as you've heard the passion through today, and I'm certainly there and still there. When you're changing people's lives, you can sometimes get overexcited. Never promise a patient they can come off their insulin, because some may not. The second thing is some patients with type 2 diabetes may not have real type 2 diabetes. I think about 10% of the type 2 diabetes diagnoses aren't type 2 diabetes. They could be misdiagnosed type 1, and then there's LADA, or they may be a true burnt out type 2 diabetes. Their pancreas isn't making insulin, so they're going to need it. How would you know not to reduce insulin any further? Anyone? You kind of, they're on a low carbohydrate diet, you're taking the insulin down, you've halved it. What would stop you halving it further? Blood sugar's going to go up, yeah. So as long as you're not going gung-ho and blind, you'll pick up these people. Okay, so the SGLT2 inhibitors, the flozins, and it's already been mentioned today. One of the actions of these is they make you pee glucose. So why are you? It's madness, isn't it? I did an infographic once of a barrel with a tap at the bottom and a tap at the top, and these are the tap at the bottom, aren't they? And you kind of start to think, well, why not just turn the tap at the top? But the other thing with these is they produce many other beneficial effects. Is now the drug companies, pharmaceutical outcomes manager contacted me earlier this week, which I was surprised by. They thought we might have some shared goals, which I was even more surprised by. But they're starting to appreciate this is happening and it gets good outcomes, so they need to combine with what else is going on to look like they're getting good outcomes, but they're also looking for licenses for these sorts of things, for the cardiac benefits. The cardiac benefits for these is very similar to the cardiac benefits from a low carbohydrate or ketogenic diet. Surprise, surprise. So these do drive up ketones. A low carbohydrate or ketogenic diet cannot, in somebody without type 1 diabetes, or even with type 1, as long as they're injecting insulin, it cannot cause ketoacidosis, full stop. These drugs can cause ketoacidosis. These drugs plus a low carbohydrate diet is probably a higher likelihood of ketoacidosis. So any thoughts on what you might do if somebody goes onto a low carbohydrate diet with these drugs? Just stop them. You're turning the tap off at the top. there's now a risk that exists, just stop them. Although in theory they might accelerate reversal, it's not worth the risk, it's not necessary.
Oh, can you go back?
Okay, so, we done? Yeah, so just marking up there at the bottom the drugs that we've covered to say which ones we need to stop. So now the medications that with no short-term increased risk. So these are, you're busy, we've got 10, 15-minute appointments, there's a lot to go on in these consultations. Which ones can you not kind of, I don't need to worry today. These are these guys, the metformin, the GLP-1s, the glitazones, the gliptins. I've not put a carbos on there, which is in the BJGP paper, but no one's really on it anymore. And interestingly, thinking back to Keesar's presentation, bitter gourd. Does anybody know why bitter gourd might help, and it links to a carbos, why bitter gourd might help blood glucose? It's got a amylase inhibitor, so nature's amylase inhibitor in it. So if people are going to eat carbs and they eat bitter gourd, it's effectively like taking a carbos, which is really interesting. So metformin, loads of different actions, isn't it? Loads and loads of different actions. We still don't fully understand how it works, but one of the things it does is it inhibits the liver making glucose. Any thoughts what you need to do with this when the day somebody goes on a low carbohydrate diet? Yeah, it doesn't matter, it's fine, you can leave them on it. So they can continue. I actually always take the opportunity to review risk of side effects. I'm picking up quite a few patients that were having GI side effects that hadn't been put down to the metformin, and when you've got this opportunity to explore it, there is quite a few patients, as you'll see at the end of our patient, who have had diarrhea for years and didn't know why, and then ended up on loperamide, one patient, loperamide, codeine and amitriptyline. They were on to sort their diarrhea and abdominal pain, but they weren't sure why they had it, and they've had gastro investigations and all sorts, and it was the metformin. So review that. Metformin obviously can have some benefits, so it's not a bad idea necessarily. GLP-1s, again, probably a range of actions. Probably the most important are they'll slow gastric emptying time and probably also have a benefit of satiety on the brain. Any thoughts on what you must do day one of somebody going on a low carbohydrate diet with these? Trick question, this one. Nothing, doesn't matter. No risk. Again, for any patients, again, the behaviour change can be hard for people. If they are getting some satiety benefit from it, stick with it for a while. I personally think the goal should be off within a year, often sooner. It shouldn't be seen as a long-term treatment option if they've got support for the behaviour change, but it may provide some benefit. The pharmaceutical rep was trying to suggest that these could be used as adjuncts to behaviour change for people, which maybe there's a market, but I mentioned as long as that doesn't become the focus. Glitazones, which I can't remember the last time I saw these being used, but there may be a few patients you have out there on them still. One of the mechanisms by which they work, they increase insulin sensitivity in muscle and fat. What happens when you increase the insulin sensitivity on fat? What does insulin do? One of the actions? Store more fat, it tells the body build fat. So one of the side effects of glitazones is weight gain, isn't it? So again, let's start turning our paradigm on its head. Obesity does not cause type 2 diabetes. Obesity is associated with type 2 diabetes. If we could endlessly grow fat stores, we would never get type 2 diabetes. We get type 2 diabetes when those subcutaneous fat stores have hit their limit and there's no more storage space, and the body's got to try and unpack through the liver, raising blood glucose. Risk-wise, day one, if somebody is on these, none. Long-term, probably the risks outweigh the benefits for the kind of known serious side effects of these. So if they are, the goal should be to stop, but you don't need to do it day one. The gliptins, what do? So they stop the breakdown of endogenous, so body's own made GLP-1. It's a great idea, really. A reasonable plan. They're going to help this insulin secretion. Might help the body. Day one of going low carb. Any risks? Yeah. No. Yeah, there's no risk with them actually in the short term. recommendation though is usually, I don't tend to stop at day 1 just in case it was having some benefit. You don't want a disappointed patient 3 months later who's made loads of benefits. They stopped a drug that was benefiting, the blood sugar hasn't changed as much. So I tend to leave them on for the first 3 months. The general consensus across clinicians though, it seems to be these don't do anything on a low carb diet. Nothing. And I don't know if they do that much in many patients anyway. But so there is a risk going to come with any drugs. The general thing is just stop them within the first few months. So in summary, we're keeping it really simple. And again, this is what I'm really keen you leave with today. This stuff is really, really simple, but it's got to be simple for our 10-minute appointments. So the insulin, sulfonylureas, glutathione, reduce or stop. SGLT2 inhibitors, stop. GLP-1s, glitazones, DPP-4 inhibitors, likely stop in the long term. Metformin, optional, where are the pros and cons. Unfortunately for the current criteria for type 2 diabetes remission, they said you've got to be off all drugs. I think that's unfair for some patients that may benefit from metformin. So I keep an open mind about it, but recognise it has its risks as well as benefits. Just highlighting this, so get this from the paper, but it's easy to refer to table in the paper, because although this stuff is quite simple, until you've done it a few times, it takes a while to sink in. So you can access that. So finally, back to our patient. So, say he's 65 now, not 64, we're a year on. Type 2 diabetes is now in remission. So you'll see his hypertension has improved. He's no longer got fat markers of fatty liver. CKD3 has not got any worse. He's no longer obese, he hasn't got IBS, he's not depressed. HbA1c is 46, ALT is 28, triglycerides are 0.9, HDL cholesterol is 1.6, blood pressure is 135/70, his BMI is 28, weight of 90, not on the glipizide. Decided to stay on the metformin, but he reduced the dose. Not on the liraglutide, not on the loperamide. So why is he not on the loperamide? Because he's no longer got IBS due to, or offset battles due to the metformin with the lower dose. Ramipril decided to stay on. His blood pressure is not low, possibly some renal benefit. Had he not had any renal disease, only sign of CKD3, and his blood pressure had been kind of a bit lower, probably would have titrated that down. Torvastatin, bit of a debate. I really separate the lifestyle and the statin argument. So the world can get muddy when you start to kind of combine these things, I think. So we're doing a low carbohydrate diet, that's improving all of these markers. You've got a much lower risk profile now. So if you run this patient now through Q-risk, they're going to have a hugely lower risk of cardiovascular disease, predicted cardiovascular disease. Then you can have that new conversation like we should have had first time around. This is the predicted benefit of a statin. Your risk now is 2% over the next 5 years of a cardiovascular event. Do you want to reduce that by 30%? So 1.5, 1.2 chance, so you reduce it by an absolute risk of 0.8%. Do you want to stay on the statin or not? It's a patient's decision, isn't it? We're there to be expert advisors. This patient wanted to, other patients absolutely do not want to continue on it. Interestingly, statins increase your risk of type 2 diabetes, which many of you, I think it's 1 in 100 increased risk, which is interesting, isn't it? Citalopram off, so depression and obviously need for SSRIs will be diverse, and I certainly don't want to say this is the fix for depression, but as many of you probably have met, whether it's due to people who are now in control of their health and their life, whether it's due to a biological effect of the diet. Personal point of view, if I eat a really high carb, junky food diet, I feel like rubbish. So no longer needed it, felt great, came off that. And then the last 4 on there are make believe for this, but off them all. Now following a low carb diet and continuing in the gym. So that's kind of good medicine.